Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
I'm great. Thanks for asking.
All right. Welcome to Dental Webinar Series. I'm just going to read Dr. Hafsa's bio. Dr. Hafsa had an undergraduate degree from India and went on to the Rutgers School of Dental Medicine for a program in orofacial pain, TMJ disorders, and dental sleep medicine. She graduated from that program, and she's currently a graduate in a graduate program, Endodontics at the University of Michigan in Ann Arbor. Research interests includes post-traumatic trigeminal neuropathies, artificial intelligence to study cortical areas of brain during pain response, and the utilization of extraoral nerve block, twin block to manage TMJ joint disorders. Dr. Effendi, thank you for your willingness to participate in our program today. Please, the floor is yours.
Thank you for inviting me over, and I'd like to share my screen and go forward given the time restraint. Okay, I guess my screen is visible now?
Yes.
Okay. So I don't think if we would be having a discussion-like session, but then if there are any questions, I would be sharing my email at the end of the presentation, and feel free to shoot any questions. It's just the fact that, like I said, the whole field itself is an ocean, and the topic itself is very huge, so I had to make it super concise, and I just tried to be as concise, as precise in my slides as I could be, and tried to make it more clinically relevant. But let's just go ahead. I know it's slightly dry. It's more of a neuro topic. So like I said, I would be talking about trigeminal neuropathies following dental procedures. You gave a background, and I graduated from Rutgers with a degree in orofacial pain. I was also trained in Temporomandibular joint disorder management, and I was also trained in management of obstructive sleep apnea, like dental sleep medicine. And these are all hot topics in dentistry right now. So what really happened was that I found my interest in trigeminal neuropathies, neurological disorders, and nerve injuries. And based on that, I also took up a research project, which then became my thesis project. And that was also related to neuropathic pain. And I would not be touching any base with my research because that's all epigenetics, and I did that on an animal model. But then I would just briefly be talking of what dentists can encounter in their clinical practices. FYI, I told you my speaker notes are not working, so it's just gonna be a discussion. I don't think I really need my speaker notes, but anyway, let's go ahead. Hang on, okay. Before we go any further, we are going to talk about pain. And as we know, pain, as defined by International Association for the Study of Pain, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, are described in terms of such damage. So there are different types of pain. What you guys commonly know is like acute and chronic pain. And acute is, of course, something that warns you of impending damage or a noxious stimulus. And chronic is something that, say, for instance, like remains and persists beyond the normal time of healing, which would be like, say, about 3 months or something. We as pain people normally talk of physiologic and pathophysiologic pain. Physiologic pain is normally the pain which is called normal pain. Again, serves as a warning signal, tells you of an impending damage or a noxious input. But pathophysiologic pain does not seem to have any function, any role as such. It's the pain that would persist beyond the normal time of healing, and it's just malicious, in other words. And as orofacial pain people, we deal with pathophysiologic pain like more often. So coming on to the classification of pain. So on the basis of origin, it could be divided into nociceptive pain and non-nociceptive pain. And nociceptive is your somatic pain, your visceral pain. And your somatic pain would be like your pain from the muscle, joint, tissues, your dermal origin, mucosal origin pain. And then visceral is like the one that emanates from the deeper organs. Coming on to your non-nociceptive pain, which would include your neuropathic pain and your sympathetically maintained pain. Neuropathic pain is what I would be talking about today. And as I mentioned, it's pathophysiologic pain. It's a pain that does not really serve any purpose, and it persists beyond the normal time of healing. And sympathetically maintained pain is when the sympathetic nervous system gets involved, and it's an ocean, it's a different entity. I, as an orofacial pain personal, did encounter it once or twice. So in orofacial pain region, like, it's highly unlikely to come across it. I just mentioned it here so that you have a basic idea that sympathetic nervous system involvement can also help to maintain pain for a longer period of time. And the management strategy differs entirely from that of neuropathic pain. But you as dentists are more likely to encounter neuropathic pain. And that's what we're gonna talk about further. Before I go any further, I would like to talk about the functional anatomy of the nervous system, which is just the basic. We all know it is composed of central nervous system. We also know that it includes peripheral nervous system. And your central nervous system would have your brain, your spinal cord. Your peripheral nervous system would be divided into somatic, into autonomic nervous system, just the basics. And also, this is just a brief overview of how your neuron looks like, because we would be talking briefly about trigeminal nerve injuries and the fact that neuropathic pain that we're interested in begins at the periphery, and it starts with the damage to the first order neurons, hyperexcitation of the first order neurons, and that further causes peripheral sensitization. So this is how a neuron looks like. Basically, there are axon terminals, there is a myelin sheath, and there are unmyelinated neurons as well, like your C polymodal fibers. And I would actually shed some light on the different types of fibers as well. And then you can see Schwann cells. There is an axon that just joins the cell body. Then there is a nucleus right there, and then there are dendrites. And this is what happens. This is essential for synapse, for action potential, for impulse propagation. So coming on to classification of neurons, you have your afferent neurons, and then you have your efferent neurons. We are interested in afferent neurons as pain people because afferent, as the term suggests, is something that deals with sensation. And efferent neurons, also known as motor neurons, are the ones that deal with the motor sensation. So afferent would have your pain, touch, pressure, temperature, all the sensation that is related to the higher order neurons through the afferent fibers, and they are further divided. So this basically chart summarizes a couple of afferent neurons. For instance, A beta fibers are largely and thickly myelinated, and because they're thickly myelinated, their velocity, conduction velocity, is very fast. You can see it's 40 to 70 minute per second, miles per second. And then it has what does it conduct? It conducts the light and mechanical, the touch sensations basically. And that is also because it's thickly myelinated. Comes your A delta fibers, which are small, they are lightly myelinated. And what would they do? They would basically take care of the intense mechanical and thermal stimulus. And then are your C polymodal fibers. They are small and they're unmyelinated. And what's amazing about them is that the reason they're called C polymodal fibers is because they're capable of transmitting thermal and mechanical as well as chemical impulses. So they take noxious input and what's amazing is also that they're responsible for the dull aching pain, because fast pain would be your A delta fiber and the slow pain would be your C fibers. The reason why A delta has a fast conduction is because it is still lightly myelinated. You need a myelin sheath in order for the neuron to conduct the impulse faster. But because C fiber are unmyelinated, they're responsible for the slow pain. And there are papers on it, but I'm just trying to be very brief so that you get an idea of what fibers we should be talking about and what fibers we're dealing with. So A beta fibers, again, are not capable of transmitting any noxious impulse, any noxious input. They are just responsible for the light mechanical touch. But then in certain cases, for instance, giving you an example of allodynia, take an example of sunburnt skin, for instance. When you're sunburnt, your whole skin feels irritated, and the hyperexcitability is such that even lighter touch to your skin can result in a pain-like feeling, a burning sensation. That is because of the fact that your A beta fibers are excited in that moment, are basically activated in that moment. And now, instead of transmitting the sensation of light mechanical touch, they're transmitting the sensation of burning pain. That is only because they're like kind of excited because of the hyperexcitability of the first order neurons and peripheral sensitization, resulting in allodynia. And so is the case in trigeminal neuralgia, where just a light touch, or say even a hair strand on the face, kind of results in hyperexcitation of the neurons and an electric shock-like pain. So it's not normal, by the way, it's just pathological if your A beta fibers start transmitting pain impulses. Since we're interested in nociceptors, we know that nociceptors are primary afferent neurons. They have free sensory nerve endings that are capable of responding selectively to a noxious stimulus. These sensory receptors lack the specialized capsules covering the axons and are known as free or bare nerve endings. And many of these free nerve endings respond to noxious orofacial pain stimulus, and they act as nociceptors. And these are your first order neurons, your primary afferent neurons. So, the free bare nerve endings are basically the ones that lack a specialized capsule, which normally covers the axons, like your A beta fibers, which are thickly myelinated. They have this capsular covering, which makes them ideal for light and mechanical touch. But because our nociceptors lack these capsules, they become pain transmitters, and they respond to noxious orofacial pain stimulus. And what are the types of nociceptors? We just spoke about A delta fibers, which are thinly myelinated. We have our C polymodal fibers, which are totally unmyelinated. They're responsible for the last pain, or the deep and the dull aching pain from the orofacial pain region. And a recently discovered group of nociceptors is our silent or sleeping nociceptors. So there's still research going on in this area. And what's amazing is that these nociceptors get activated only after activation of a certain region. Normally, they do not respond to pain, but then after injury, after noxious input or stimulus, these silent nociceptors kind of wake up, and then they start kind of adding to the pain cycle, and they start transmitting pain as well. And let's say they just kind of like, it just becomes a whole amalgamation of a whole lot of pain input from the periphery when all three of these nociceptors kind of work hand in hand. And it's more often seen in pathophysiologic pain that persists beyond normal time of healing. So silent or sleeping nociceptors would ideally be responsible for chronic pain states. Now, coming on to trigeminal system and teeth. So we as dentists are working very closely with trigeminal thalamic tract, and we are working very closely with the trigeminal system. But kind of what we see in the oral cavity is just the teeth, and we just forget that our role as a clinician, as a pain person, I feel every dentist somewhere or the other is especially like fields like endodontics, especially the fields like oral and maxillofacial surgery. We're really trying to help the patient and trying to eliminate the pain. So knowingly, unknowingly, we are all working very closely with the trigeminal system, and it is possible that inflammation, even in a single tooth, could lead to hyperexcitability of the second order neurons. So it's like, it may not happen in every case, rare cases, but then it's true. And I would show you just some examples of how seemingly innocuous stimulus can sometimes result in hyperexcitability of the central nervous system, which we call in our terminology as central sensitization. So any minute trauma to the trigeminal system or any excitation of the trigeminal system can eventually affect the higher cortices of the brain and result in central sensitization syndrome. From a clinical viewpoint, 3 pain disorders are unique to the trigeminal system. Tooth pain, we as dentists, we are directly involved. Trigeminal neuralgia, well, neurology people and orofacial pain people deal with it. And migraine, again, neurovascular headaches, and neurology people and orofacial pain people. So I found this very cool picture. I thought I would put it here. I love it because it just shows how close we are to the trigeminothalamic system, how close we are to the brain, to the spinal cord, and to the dorsal medullary horn, basically. We as dentists are often looked upon as mechanics of the tooth, but I feel like there's so much more in our hands and there's so much more knowledge that we must possess, given the kind of cases I have seen in my residency, and given the fact that small routine dental treatments gone wrong could basically jeopardize the patient's life, the patient's well-being, actually. And trigeminal system is kind of really susceptible to pain and pain disorders, and anything related to the trigeminal system is horrible. Like, I've struggled with cluster headache myself, and it's one of the most horrible suicidal pain disorders that one can have. So that just kind of also makes me realize that anything related to the trigeminal system must not be taken easily. It definitely creates hazard if not taken care of, if gone out of hand. And like I said, we're working so closely with the teeth, which are so closely associated with the trigeminal system, and we are definitely responsible. And also, I would say, we're also like low-key putting the patient at risk of pain disorders, chronic, acute. Before we go any further, I like this image, and I would like to talk a little bit about what happens in the higher centers of the brain, the peripheral sensitization and the central sensitization, and how it is related to the teeth. So let's take an example of V2. Say it's basically transmitting noxious input from the maxillary teeth, which would further go in your trigeminal ganglion, get processed there, say impulses from your A delta and C nociceptors. Further, after getting in, and like I said, trigeminal ganglion is a primary relay center. It acts as a strategic locus where the impulses are further, I would say, are further changed and then either taken to the trigeminal spinal tract, which will have your main nucleus, the main sensory nucleus, the one that we're interested in. And even this main sensory nucleus is divided in 3 parts. It has your subnucleus oralis, it has your subnucleus interpolaris, and then it has your subnucleus caudalis. Caudalis, as the name suggests, is the most inferior caudal of the nucleuses, and this is extremely important to us. This is where a whole lot of stuff is happening. And after terminating in the nociceptive information, the noxious input from the trigeminal ganglion that further comes here, synapses here. This is where the synapse to the second order neuron occurs, and that shall further, depending on the intensity of the noxious stimulus, go to your thalamus. And in thalamus, it'll get processed further and synapse with the third order neurons. And then that will further go to the cortical areas of the brain. And what happens in the cortical areas of the brain is that it gets processed. And depending again on the noxious input, it would either send signals of descending pain modulation, which could be facilitatory pain modulation, or it could be inhibitory pain modulation. Inhibitory would result in, of course, taking care of the pain, and a facilitatory pain modulation would, of course, warn your body of a damage, and that's how central sensitization starts, and that's how chronic pain states start if the peripheral stimulus, noxious stimulus, is not taken care of. So in cortical area, I would say somatosensory cortex is of utmost importance. Brain's cortical areas, just briefly, are divided into the frontal cortex, temporal cortex, your parietal lobe, and then your occipital lobe. And it lies somewhere in the parietal lobe, and somatosensory cortex also kind of deals with the pain, the emotional, the cognitive response of the pain. So I don't want to like really confuse you guys further. I don't know how important it is to you guys, but we had to understand it as like residents in my previous residency. And I think just a brief overview for you guys to understand that the first order neurons are synapsing at the subnucleus caudalis. The second order neurons further synapse at the thalamus, and then that further takes impulses to the cortical areas, the higher centers of the brain, where it gets processed as pain, and then follows a cascade of descending pain modulation, which would either inhibit that pain or facilitate that pain. Just a brief overview for you to understand how human brain is so closely linked to the trigeminal system, and how so many times the idiopathic dental pain, the dental pain that we fail to understand, the dental pain that persists beyond normal time of healing, is related to this system, is related to the brain, to the human brain, to the higher centers of the brain. So, because I would be using the term central pain, central sensitization more often in this presentation, just so you guys understand. So this is a representation of the homunculus, and what's even amazing is that you guys can appreciate they have basically zoomed in on the lips, on the tongue, on the fingers, and they're basically trying to tell us that this is how it's distributed in human brain. That's partly because these areas are richly innervated, given the fact that these areas are highly sensitive. So majority of our brain, when it comes to sensation, when it comes to pain sensation or regular sensation, is represented by these areas actually. So these areas are highly sensitive, extremely, like I said, susceptible to noxious input. And you can see the eyes, the lips, the tongue, the fingertips. So they would represent the majority of it. And even if you like Google, you can see these pictures of the homunculus. So this is kind of like a pictographic representation to simplify things for you. And we're like directly working here in the mouth. Now coming on to neuropathic pain, which we should be speaking about. So IASP defines it as pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. It would include dysesthesia, unpleasant, abnormal sensation, paresthesia, the feeling of pins and needles, but no pain. And a mix of symptoms, with most patients describing their pain as burning, shock-like, electric-like, deep, aching, stabbing, numbing, itching. So with neuropathic pain, just for your knowledge, it could either be episodic, which would include trigeminal neuralgia, or it could be continuous, which would include your PTTN. And I would be talking about PTTN, which was my research area, which was my area of interest. But because we're talking a little bit about episodic neuropathic pain, let's talk a little bit about the classification. So depending on the site of damage, it could be central neuropathic pain or it could be peripheral neuropathic pain. Central would mean that there is a dysfunction in the central nervous system, which would also include a lesion of the central nervous system, a meningioma, a tumor, an injury, anything that would result in central neuropathic pain. Peripheral neuropathic pain is what we as dentists may encounter because it starts at the periphery, say a damage to the trigeminal nerve in the infraorbital dermatome, which would result in peripheral sensitization and further cause central sensitization and chronic pain state. So central neuropathic pain is something I'm not talking about. It's just a different entity. Peripheral neuropathic pain, yes, because as dentists, I feel we should know about it. So since, like I said, I was talking about episodic and continuous neuropathic pain, I think trigeminal neuralgia, I would throw some light on it. You can read the definition. You can find the definition online as well. IHS describes it as unilateral, brief, electric shock-like pain. It is abrupt in onset and termination. Distribution would be limited to one or more divisions of the TN, and it is triggered by innocuous stimuli. Like I told you guys, light touch to the face, even a hair strand on the face or a wind blowing on the face would result in a pain-like stimulus. Why? Because your A beta fibers are sensitive right here, and they're doing the job of transmitting noxious input, which they shouldn't be. And the classic sign is the electric shock-like pain, and there is a different definition by IASP as well, which is almost the same. It's like usually it's unilateral, severe, brief, stabbing, recurrent episodes of pain. Now, why is it clinically relevant to us? Because differentiating it from odontogenic pain, especially from acute pulpitis, is difficult for some clinicians. The pains, basically both of them, the acute pulpitis and TN, presents as sharp shooting pain. Amazing enough, diagnostic block would eliminate pain in both cases. So that just also confuses us further. And a thorough review of patients' history would provide us important clues. So you need to ask the patient about previous attacks of intense, sharp shooting pain that lasted a few weeks and suddenly disappeared, only to return again, because that doesn't happen in dental pain. They just don't disappear and then reappear after a while. But then there is ifs and excuse me. So there are ifs and buts there. What if the patient presenting with trigeminal neuralgia symptoms has no history of previous episodes? So in that case, you will have to run a small diagnostic test yourself. So you need to ask the patient about the duration of the attack and presence of a refractory period. So it should ideally last from 30 seconds to 2 minutes versus pain of acute pulpitis, which will last for several minutes. And presence of a refractory period is a very important diagnostic feature here. Acute pulpitis does not come with a refractory period. So I would suggest that you guys take a Q-tip or take a cotton pellet and induce an attack of classic trigeminal neuralgia by either like swiping it across the territory of the nerve or across the face. So for instance, say the mandibular nerve involvement is suspected, you guys should just lightly swab this area or like lightly run a cotton pellet around this area, and that should ideally trigger it because there are triggered zones in trigeminal neuralgia. And if there is a refractory period present, an attack will not occur once you try to trigger it again. So your patient would describe the pain as electric shock-like pain. Of course, you would see your patient in excruciating pain once the attack gets triggered. And when you try to like lightly touch the area again, there would be no attack, basically. Classically, there should be no attack. Why? Because of the presence of refractory period. So that right there is a sign. And also it is suggested that application of cold stimulus to the tooth will cause an exaggerated and painful response in acute pulpitis, which we as endodontists know. So that should also give you some leads. And percussion of the tooth, of course, for symptomatic pulpitis or periodontitis is also one of the features to differentiate between the two. This is just an image. That's what we normally do, like in the territory of the trigeminal nerve, just use a Q-tip or use a cotton pellet or just lightly touch the area with anything in sight. Even a worn fray filament should help and elicit an attack. Another thing that just kind of confuses us is the presence of cracked tooth, and it can also create a problem when distinguishing between classical trigeminal neuralgia and odontogenic pain. So as a result of involvement of the dentine, the pain can be of sharp or short duration, and in many cases, the crack may not be clinically or radiographically evident. So we would suggest that apply some oblique pressure on the involved cusp and probing the fissure with sharp explorer. But then I still remember in my previous residency, so like I said, it's not only us dentists who are like kind of getting confused between pain of acute pulpitis or cracked tooth versus pain of classic trigeminal neuralgia or neuropathic pain. It's like we were sent a case by a dentist actually, and his patient was scheduled for a gamma knife surgery, which is an invasive procedure and is used for permanent management of trigeminal neuralgia. Amazing enough, we ran a few tests and we realized that it wasn't trigeminal neuralgia. We realized that it was a J-shaped lesion. It did seem like it was the pain of odontogenic origin, but we weren't sure. So we ordered a CBCT, and it turned out to be a J-shaped lesion. And we were like, you see, like as pain people, as pain personals, as orofacial pain physicians, possessing right amount of knowledge of dentistry and right amount of knowledge of neurology kind of helps sometimes, because this patient who had nothing but dental pain was scheduled for such an invasive procedure by a neurologist, because a neurologist would not go in your mouth and tap on your teeth. And she had very confusing signs and symptoms. But because I and my faculty members, we were actively working with the neuro people, and we have significant knowledge of dentistry as well, we were able to discern it, and we were able to decide whether it was odontogenic or non-odontogenic pain. And we kind of saved the patient from a very invasive procedure, something I'm proud about. And I also did a case presentation on that, and I also presented that poster. Sorry, I don't have the pictures for it right now, but if you guys send me an email, I may share that case with you, actually. It's very interesting. So this image I found online, but trust me, I've seen like cases like this, and it's not unusual for us as pain people to come across cases where the patient has undergone multiple root canal treatments only to find out a solution to the pain, because the patient is so convinced that the pain is emanating from one of the teeth. And this is a typical representation of post-traumatic trigeminal neuropathy, which was earlier called as atypical odontalgia in literature. And let's just talk about it, because I think that's where most of us dentists are getting confused, and that's what most of the dentists are increasingly encountering these days. So painful post-traumatic trigeminal neuropathy, also short form is PTTN. So it is a unilateral facial or orofacial pain following trauma to the trigeminal nerve, with other symptoms or clinical signs of trigeminal nerve dysfunction. So this is International Headache Society's description. So for the record, the traumatic event could be mechanical, it could be chemical, it could be thermal, or it could even be caused by radiation. So you would be amazed to know that seemingly innocuous stimulus also is capable of generating post-traumatic trigeminal neuropathy, and we'll talk about it. So what are the diagnostic criteria? So you will have a history of an identifiable traumatic event to the trigeminal nerve. The patient would always report that something happened. Oh, I went to the dentist, he cleaned my teeth. I went to the dentist, he gave me a nerve block. I went to the dentist, he did a root canal treatment, or he extracted a tooth. So there is a traumatic event underlying this cause. And clinically evident positive hyperalgesia. Hyperalgesia, as is known, is basically an exaggerated response to a painful stimulus. And allodynia, as you guys know, is a painful response to a non-painful stimulus. Like I said, like what happens in trigeminal neuralgia. So, or it could even be negative, hypoesthesia, lack of response to painful stimulus, or hypoalgesia, no response. So these are like all signs of trigeminal nerve dysfunction, and the pain is located in the distribution of the same trigeminal nerve which has been affected. For instance, it was an IAN nerve block, and then the patient tells you that I have pain around my mandibular nerve territory, and it's constant, and it's burning, and it feels like pins and needles. So that should alert you right there. The pain would be developed within 3 to 6 months of the traumatic event. What's even amazing is that, and why it feels so confusing to a lot of dentists, is because immediately it's highly unlikely that the patient would report pain. It's often after weeks that the patient comes back, and then you check the radiograph and everything seems absolutely normal. And you're like, okay, when I rendered the patient pain-free, and when the patient just went out, he was like, absolutely okay. I discharged the patient, no pain, no complaint, even like for the next 2 weeks. And then suddenly the patient returns back with like increasing intensity of the pain in the same area. So that's where it becomes confusing as well. So according to the IAH classification, it is an umbrella term, and it was normally used to describe trigeminal neuropathy attributed to acute herpes zoster, your shingles, post-herpetic neuralgia or neuropathy, your painful trigeminal neuropathy, which can be attributed to multiple sclerosis, which is a central syndrome disease, demyelinating disease basically, and painful trigeminal neuropathy attributed to space-occupying lesions. But then, for us dentists, we have come across the term atypical odontalgia very often, and IHS described that term as continuous pain in one or more teeth or in a tooth socket after extraction, because, of course, extraction sites were the main hotspots for atypical odontalgia. And, of course, in the absence of any usual dental cause. Like I said, radiographs would appear to be normal, clinical evaluation would appear to be normal, there would be no lesion, proper healing would have occurred, yet the patient would report pain in the same territory. And just for your knowledge, this term is obsolete. We would use the term PTTN, post-traumatic trigeminal neuropathy, instead. And I would say the term dysesthesia, which is an abnormal feeling accompanied by pain, is a better description of what they mean. Also, in the past, they have used terms like idiopathic odontalgia, like phantom pain and stuff like that. But again, we are sticking to the term PTTN. So what are clinical characteristics of PTTN? Normally in your practice, you would find it in maxillary, premolar, and molar areas, but then nothing comes to you as a textbook case. It can also be found in the mandibular, premolar, molar areas on the same side, and it can normally appear on the same site. For instance, like the patient kind of like reports pain in the mandibular, maxillary, premolar, and molar area, it's highly likely that on the same side, within a few weeks, patient would start reporting pain in the mandibular, molar, and premolar area. And like I mentioned earlier, it's all because of the hyperexcitation of the central nervous system, because there is a central component. And the human brain is an amazing tool. It just basically, like I said, if there is a central sensitization syndrome, it just affects everything, and it just basically excites everything. So like I said, it might have originated in the maxillary area, but the patient would eventually start feeling pain in the mandibular area. So it can be present in an area of a tooth extraction. It might be unilateral, and it may later cross the midlines of mandible or maxilla. Again, central sensitization doing that. And it may even spread to the face in later stages as a result of central sensitization. So talking of frequency and duration, so it is continuous, almost continuous pain. Like patient would always tell you of a background persistent pain that never goes away. So that should alert you that, oh, PTTN is probably what's causing this. And it is present almost every day, although there is no consistent time pattern, and there are no pain-free remission periods, unlike trigeminal neuralgia. The patient would present with pain 24/7. The intensity may vary, but then the pain would stay. Quality and intensity, so it is normally described as dull and aching, and it may have a burning or throbbing component, and it is sometimes accompanied by occasional bouts of spontaneous sharp pain, like just occasional bouts of exaggerated pain and a period of exacerbation, I call it. And it will have variable intensity. It ranges from mild to severe, but it is not as excruciating as trigeminal neuralgia. And associated features. So some patients may report a feeling of swelling in the area, even when clinical examination does not reveal any swelling. And this needs to be noted because most of my patients would come to me after a whole bunch of extractions in the quest for analgesia, and would then report a feeling of swelling or a feeling of a mass or a feeling of inflammation in a certain area, which to me would appear seemingly normal, which would be like healed basically clinically. That's a subjective feeling, and that's central sensitization, the human brain doing its job. And I still remember, so this one case, I just want to like talk about it because this changed the whole course of my career, and that's what made me interested in trigeminal nerve injuries. This one patient who had, so he reports that he had pain following endodontic procedure, and that endodontic procedure seemed to be okay, perfect radiographically, but he says that his pain didn't go away. So in quest for analgesia, like any other patient, he went ahead and he got more endo treatments done on the same side of the maxilla. And following that, since he was not receiving any relief, in a couple of months, he went ahead and got that initially treated tooth extracted. And this is so normal for these patients to do that. You got to note it. And he got that tooth extracted, didn't help. And I would say, as an orofacial pain person, I'm sure that just increased his pain. That just basically marred his situation. And then after getting that tooth extracted, he went ahead and got more extractions. So this patient reported to our clinic after 1 year of that endodontic therapy that started the pain, basically. And when he reported to us, he reported somewhat like this, like he had an entire quadrant extracted. And he was exhibiting signs of depression, and it had been a year and he was still in pain. And in his own words, he had lost his job, he had lost his family, he had lost his peace of mind, and he was turning towards alcoholism. Nothing was really helping him, no pain medications. He was growing dependent, and a subjective feeling of swelling, of inflammation was still there, and it was seemingly normal to the naked eye. Unfortunately, he came to us and came to our clinic so late. We decided to basically start it, but then again, with time, these cases become more difficult. What I personally feel is that had the dentist recognized that it wasn't the endotherapy, it was probably the host that was susceptible to developing post-traumatic trigeminal neuropathy, and this person needs to be sent to an orofacial pain person, I think this would have been taken care of a long time back. But instead, they went ahead with more endodontic therapies. He went to the new dentist who got more extractions done, and nothing helped him. And by the time he got to know about us, it was a year. We tried to put him on medication. We tried to talk to his primary care physician. And as we started rolling, as we started looking into the case, and as we started to determine a treatment strategy, 2 weeks from his visit, we received a note from his doctor that he committed suicide. And like I said, this patient was definitely exhibiting signs and symptoms of depression. Like I said, his whole financial situation was marred. He had lost his job. He was depressed. All he did was talk about the pain. All he did was like touch this edentulous area constantly, unknowingly with his tongue. And he was low-key obsessed with it. And he committed suicide. And it was a big thing for me, because as dentists, you don't come across cases like that. Someone who was just in your dental chair, where you were just planning a treatment strategy, where you were just planning to help the patient out. You just discovered that this one endodontic therapy led to so much in his life, and he took his life. He committed suicide, and I feel like that just changed everything for me. Okay, now briefly coming on to pathophysiology of PTTN. We already know that macro trauma to facial bones or orthognathic surgery would of course have an impact on the nerves, no brainer. But then what's amazing is that even minor trauma to the branch of trigeminal nerve, following routine dental treatments like endodontic therapy, like apicectomy, like your teeth extraction, like your periodontal surgery or dental implant placement, this would cause PTTN in certain hosts. However, what's even amazing is that you may encounter cases where crown preparation, drilling of dentine, and something as innocuous, seemingly innocuous as periodontal scaling may also, cause post-traumatic trigeminal neuropathy and render the patient with a central sensitization syndrome. And we have seen it like needle stick injuries. It's not uncommon. So just keep your mind open and understand that this may happen, and it's like you taking the right kind of history, asking the right kind of questions can save the patient from further invasive procedures, and you referring the patient out at the right time, realizing that your job as a dentist is over and now it's the time for an orofacial pain personal to take over, can basically help the patient right in the initial stages. So just for the record, even periodontal scaling and crown prep can cause it. Now, clinical evaluation. What we do is that If the affected area is an edentulous tooth site, so it can be tested first by using a topical anesthetic ointment. But then if there are teeth in the area, say for instance, after an endodontic therapy, and you suspect that it's PTTN, I would suggest that a series of diagnostic anesthetic blocks or local infiltration around the areas can help. And there should be a pattern. So for instance, the patient tells you that the pain is somewhere over here in the incisor area. Start from the premolar area. Don't just like jump on in here, and slowly and steadily work your way through these local infiltration nerve blocks and go on to the central incisal area. And also keep using a visual analog scale, both before and after using the diagnostic anesthesia, because again, pain is a subjective measure, and there is no way we can quantify pain except for the patient's own report. And for that, you need a scale, a visual analog scale, ideally. So like I said, what needs to be noted in this case is that a diagnostic somatic block of the tooth or area in question would produce an equivocal response. That means you would deliver local anesthetic. Ideally, if it's dental pain, the pain should go away. But then if there is an equivocal response, that means your patient tells you that, oh, the pain has lowered a bit, but then it has not disappeared. That should alert you right there. This is one of the classic things that we do in order to discern pain of odontogenic origin from that of non-odontogenic origin. And in this case, you should suspect post-traumatic trigeminal neuropathy. And yes, there is another test, we call it cold test. So we can apply stimulation to that area of the mucosa, apical mucosa of the affected tooth. We call it Zaguri test because Dr. Juliana Gomez Zaguri was the faculty at Orofacial Pain Clinic at Rutgers that time, and she came up with this test. And actually what we noticed was that it results in an exaggerated, prolonged response, the mucosa, the pain stimulus on the mucosa. That will also alert you and make you understand that there is definitely a central component that plays a role. And I would like to add what I have seen personally and what we have observed all throughout our residency is that if the patient tells you that the pain has gone, say, 60% following the diagnostic nerve block, or more than 60%, understand that the majority component that plays a role is peripheral component. But then if the pain persists beyond that, say if the patient says, oh, just like say 20% of my pain is gone or 30% of my pain is gone. So understand it's more like a central component, more of central nervous system involvement, more of central sensitization syndrome playing a role over there. So it's not peripheral sensitization that dominates in that case. And if you need any papers on that, I can send it to you. So this is the kind of visual analog scale that you would use. You would basically use this visual analog scale before and after the diagnostic nerve block, and the patient would rate their pain before you give them a nerve block and after you give them a nerve block. And I repeat again, the pain should not disappear completely if it's PTTN. The pain will lower down, but then it would not go away completely. There would be an equivocal response. Coming on to the management of PTTN. So I don't know if you guys can prescribe medications as dentists. I would just suggest do not try to manage, send it to us. But then yes, pharmacotherapy is the treatment of choice for post-traumatic trigeminal neuropathy. And you gotta understand, if you suspect there is PTTN, delay any optional dental treatment, and no invasive procedure or even like scaling should be prohibited for the time the patient is seeking treatment for PTTN, because you do not need more input. You do not need more stimulus to the area. Just leave the patient as it is or refer the patient out and let the orofacial pain people do their job. And just for your knowledge, we as pain people, we normally prescribe tricyclic antidepressants like amitriptyline, nortriptyline. We use gabapentinoids, which is like your pregabalin or gabapentin, a GABAergic medication. We used serotonin norepinephrine reuptake inhibitors. We use it more compared to SSRIs, the selective serotonin reuptake inhibitors, because this right here would affect both the serotonin and norepinephrine, and it's it's proven to be pretty successful. And sometimes we use an amalgamation of all these drugs. It all basically depends on the amount of central component that is there. And yes, clonazepam has also been shown to have like significant positive effect in management. So there is a proper management strategy to it. It's not that you just like take any medication and prescribe. There is a dosage that needs to be followed. The case needs to be reviewed. Proper tests need to be run, and then the dose of certain medication needs to be decided. I don't know if you guys really prescribe these medications, or if you guys, I don't know what countries you guys come from and if you're allowed to prescribe all of it. But in our case, the dentist would normally refer these cases to us for a management. So topical application, I want to touch base with it because my program director came up with this amalgamation of a topical gel that basically helped a whole lot of patients. But then going by the literature, capsaicin basically, of course, causes hyperexcitation. It causes a burning sensation, and I don't think anybody would assume that capsaicin can help. But then basically capsaicin ideally has been used and combined with aura-based gel in an ointment form and then placed under a neurosensory shield and applied a few times a day for these patients. And reports have shown that capsaicin has helped in the past. I have never done it. I cannot speak for it, but then I know that there's a whole lot of discussion going on this, and it definitely helps. Initially, it's painful to the patient. So what clinicians normally do is that they combine capsaicin with local anesthetic so that that intense burning sensation and discomfort is sort of taken care of. But then for us, what we did was that my program director came up with this gel, which was formulated for topical use. He basically combined all these medications in a pluronic gel base. It included ketoprofen, which is your NSAID, lidocaine, which is an anesthetic, ketamine, an NMDA receptor antagonist, and gabapentin, pregabalin, whatever you need. So basically a cocktail of all these medications that would be used in a PLO gel and placed on a stent and then given to the patient to be applied for 5 to 10 minutes for several weeks and a couple of times a day, so that the peripheral impulses can be taken care of. And we do this more often on the edentulous area, where we suspect significant peripheral component to the post-traumatic trigeminal neuropathy. And this has definitely helped a lot of patients. And we call it Hare's gel, but I think Dr. Hare couldn't really patent it. So Dr. Hare is the one who originated this technique. Now for differential diagnosis, it could be toothache, myofascial trigger point, trigeminal neuralgia, neurovascular toothache, which includes your mid-face hemifacial migraine, cluster headache, maxillary sinusitis, and each one of them is a huge topic, an ocean basically. I'm done with post-traumatic trigeminal neuropathy. I tried to make it as precise as possible. I don't think I did justice to it, but then if you guys have any question, please type it down here or send me an email. I'll share my email with you guys and I can give you further reading materials because like I said, it's an ocean. An entire book can be written on this topic. But then I just touched base with a few basic things that you guys as clinicians can do and few things that can help you guys recognize PTTN. A quick overview of the trigeminal nerve injuries. I have a time restraint. Uvoh, how much more time can I use?
Go ahead, maybe 5 minutes.
5 minutes, so I'll just like quickly go over trigeminal nerve injuries. I just want to talk a little bit more about traumatic neuroma. So more susceptible to injury is your inferior alveolar nerve, your lingual nerve. Causes could be your surgical procedures, again, major surgeries, bone grafting, or your episectomies, your traumatic reconstruction, your removal of bony pathology. And more frequent cases would be what you as dentists would encounter, removal of mandibular third molar, placement of endosseous dental implant, endodontic therapy, even sometimes local anesthetic injections, which I have encountered personally. Patient tells you that, oh, that doctor gave me well, he won't say an infraorbital nerve block, but then he would be like, he placed a needle here and he gave me a shot and I felt this electric shock-like pain, and then I had pain all throughout the procedure. So I wish the doctor actually had basic idea that he probably ended up injuring the trigeminal nerve, and going further with the treatment would only jeopardize the patient's situation. You should stop ideally right there, because the patient tells you the pain has not gone away, and the local anesthetic injection, instead of like relieving the pain or numbing the tooth, is causing electric shock like pain. That means you have penetrated the nerve itself. This is a basic anatomy of the nerve. This is the structure. There are blood vessels within. There is an epineurium. So you can see this is your axon. Axon is lined by your endoneurium. This whole bundle of axon lies in a perineurium, and this is what makes your fascicle. And then you have these fascicles lined by epineurium. Anyway, talking a little bit about the response to the nerve injury, females are more susceptible, older patients are more susceptible. There is a greater risk for developing neurosensory deficit, especially after placement of implants or surgical endodontic procedures. And then location of the injury, like the more proximal the injury, the greater chances of damage to the trigeminal ganglion and the central nervous system. And the more significant factor would be the type of the injury. Since we're talking about type of the injury, I would like to throw some light on Wallerian degeneration, which you guys probably know. So axons which are cut, which is your axotomy, would undergo degeneration in both directions from the injury site. So right here, this is what would basically depict your Wallerian degeneration. Eventually, if they fail to fuse with each other, fail to form a connection with each other, they would degenerate. Quickly talking about the kinds of injuries we encounter, neuropraxia, as you can appreciate, it's just a very mild temporary interruption of nerve conduction. It's compression injury, basically, due to the traction of the nerve. It is mild. There is no axonal degeneration. Nerve conduction kind of remains normal. There might be slight sensory deficit, and it could be described as paresthesia, the feeling of pins and needles. That's what your patient would say. And the recovery is mostly complete, and it occurs within several hours to a few weeks. And then you have axonotmesis, which is like more of a crushing injury, and it is significant because excessive traction or compression of the nerve will occur. Certain fibers will get degenerated, but the nerve tube will remain on contact, will remain normal, and the nerve trunk will remain intact, basically. Conduction would be decreased, and initial sensation of paresthesia, the unpleasant sensation, it may take like kind of months to improve, unlike neuropraxia. And neurosensory recovery is never complete, and patient is left with diminished response to stimulation, needs to be noted. So many times microsurgical repair of the nerve is indicated, especially when pain is present, but this needs to be done early. Don't go in after 6 months. You would only increase the pain levels. You would only cause more trauma. Neurotomesis, as the image depicts, it's a severance of the nerve. Loss of conduction will occur, and nerve, such as lingual nerve, during extraction is at a higher risk, and less spontaneous recovery chances are less. And if it's IAN, which already travels through a canal, so chances of regeneration would be high, because there is already a canal that is providing a conduit for the regeneration of the nerve. But then if it's something like a lingual nerve, which is basically in the soft tissue, there is a high chance that these fibers may not anastomose and may not regenerate and fuse in together again, because there is no conduit like a canal to do that. So without surgical repair, there is a high chance that recovery may never occur, and neurotization will never happen. Instead, a scar-like tissue will form. Quickly talking about traumatic neuroma. So it is a disorganized mass consisting of overgrowth of axons, Schwann cells, fibroblast at the end of the nerve that is damaged, and it is a benign lesion. It is not the neuroma that you guys read in oral pathology. This neuroma is related to the nerve, and I'll show you some pictures. So it is basically an attempt at repair rather than being a neoplasm. It's not a tumor, guys. And it falls in two categories. It would be a neuroma in continuity, or it would be an amputation neuroma. So this is your amputation neuroma. The nerve is severed, it's cut, and the end of the nerve forms an amputation neuroma. And this is a neuroma in continuity. Seemingly your nerve is continuous, but the injury has resulted in a neuroma formation on the walls of the nerve. And this is your lateral neuroma, the exophytic growth that can be appreciated here. And this is right here, your lateral neuroma and adhesive neuroma. So these are like different types of neuroma that we encounter. And I would say neuroma in continuity is what we often see with trigeminal nerve, but with lingual nerve, finding an amputation neuroma is very normal. So how would you evaluate it? You would evaluate these injuries by neurosensory testing, your direct discrimination, 2-point discrimination, static light touch, pain sensitivity, quantitative sensory testing. This is your typical light touch, fine sensation testing. You use a cotton wool pellet or you use a Q-tip. You do this for trigeminal neuralgia. You do it just to know if the patient can feel the same on both the sides. I do it with a Q-tip, and I use 2 Q-tips in my hands and do it at the same time on the left and right side of the territory of the right and left trigeminal nerve, so that the patient tells you right away, oh, so you know what, my right nerve, my right side, I don't feel the touch sensation the way I feel it on the left side. So that right there tells you that, you know, there is probably some effect and there is probably some sensation loss. This is your 2-point discrimination. You would use a device like this, and the patient should ideally be able to tell you if they can feel the 2 tips, and they could basically discriminate between the stimulus. This can be used as a light touch. So static light touch, this is a von Frey filament. It's a hair-like filament that we use sometimes. And this is used for your static light touch discrimination. And this right here is a device that we as pain people use for quantitative sensory testing. The patient holds a remote-like device in their hand, and you give a noxious input, say, this thing that is like basically heated, the end of this thing is heated, and a monitor is attached. My friend did a whole lot of research. He's probably attending it. His whole project was on quantitative sensory testing. And the patient basically tells you, basically the patient has the remote in their hand, and based on the level of noxious input and how the patient perceives it and the level of pain they feel, they would basically touch the remote and stop it when they feel that it's unbearable. And on the monitor, you would get a reading, and you can do it for both the sides and then differentiate what's going on. If there's a lack of sensation, the patient may not be able to detect pain easily. Coming on to management. So for management of neuromas, since they're located in soft tissue, most definitive treatment ideally would be surgical excision, but going in there surgically, invading the area surgically may result in a recurrence of the neuroma. So you've got to take that into note. And we as pain people, we basically stick to the corticosteroid regimen. We start with a higher dose of dexamethasone, or we straight away give them Medrol dose pack when we suspect a nerve injury. That's what you got to do, give them corticosteroids. A submucosal injection of dexamethasone 4 milligram into the area is also suggested. My program director, Dr. Hare, would do that all the time. Wherever he suspected a neuroma, he would basically inject dexamethasone in submucosally with the typical submucosal injection needle. So a combination of capsaicin and Orabase can also be applied to the area, like I showed you in the previous picture, using a neurosensory stent. And if you feel there is a sympathetic involvement, clonidine can be added in the regimen. It can either be applied topically or it could be administered systemically. It just depends. Well, let's not go there. That's orofacial pain personal's job. That's not your job. And like I said, what my program director would do, he would take a Q-tip, basically say it's an extraction site, it's an edentulous area. With a Q-tip, you go lightly, say your patient says, I have pain right here, somewhere in the middle, and you suspect there is a neuroma there. Start with the distal portion, go with the Q-tip, try to tap on with the Q-tip, apply pressure, come on in here until your patient tells you, oh my God, yes, this is where the pain feels. And it's very typical of your patient to kind of react when you press hard with the Q-tip around this area. And what happens is that once you find out that this is a neuroma, mark it, or just with the naked eye, get a brief idea of where you suspect the neuroma to be. And like I said, go ahead with your corticosteroid injection, 4 milligram dexamethasone subcutaneously into the area. Helps 100% and has helped our patients and basically renders the patient pain-free for a couple of weeks. That's how we are actively managing neuroma in pain clinic right now. I think you guys can do it, but then a little bit added knowledge and training would be beneficial. And I just would like to add that Neuroma's occurrence with post-traumatic trigeminal neuropathy is very common. It might be this one hotspot that is bothering patient following extraction, or it may be an apical neuroma lying at the apex of the tooth following endodontic therapy. For that, we would give systemic medication. There is no way I will go with the dexamethasone needle. I would give them systemic medication, and we would stick to pharmacotherapy. But with this hotspot of neuroma, there is a high probability that your patient would also complain of a background pain. That means a central component has also taken over, and a central component is also kind of maintaining the pain. That is that. I'm sorry. I wanted to go in more details. It's still a very long presentation. It's still very, very dry. But I just wanted to touch base with post-traumatic trigeminal neuropathy and traumatic neuroma, what to expect, what to do basically, and when to know that you've got to refer the case out. And if you guys have like added questions, or you guys need some reading materials, or you guys need to know about my references, this is my email ID. Feel free to send me an email. Feel free to contact me. I'd be more than happy to share resources with you guys.
Thank you so much, Dr. Effendi. That was a very, very detailed presentation. Thankfully we have it recorded, so you can actually listen to it again. You will definitely. Most of the questions I saw some questions here. I believe that you said, is there a psychological effect associated with TN?
Absolutely. Absolutely. So there is a research paper that shows that the psychological component goes hand in hand. But you've got to notice, it's not pain of psychogenic origin. There is a difference. The pain comes first. The pain exists, and the psychological disorder, the depression, comes into existence because of the pain. So definitely the psychological factors, the anxiety, the depression, the inability to deal with chronic pain disorders, the inability to understand where this pain emanates from, leads to a significant psychological component.
Okay. I know you did mention, so amitriptyline, as I guess you've answered.
Absolutely.
I think the key for us here is diagnosis. You have to make sure
that in very low doses, not giving it in a very high dose. We start with 10 milligram. So it's amazing that we found that it was just an accidental discovery that amitriptyline kind of takes care of central neuropathic pain disorders. That's how it was. So we are technically not using it for depression here in this case. We're using it because it's, like I said, it's in CNS, it's central neuropathic pain. So we're using it for that reason.
Right. Thank you so much. She did there, Dr. Effendi did leave a contact there, so you can reach out for more. But it's going to be available on YouTube later in the evening. You can listen to it, send it to your students. This is going to be part of our course. Dr. Effendi, this is here to stay. We have to bring you for a part 2. Very knowledgeable. I think kudos to you for your hard work, and I guess we will talk off camera. Thank you so much, guys. We're going to move on. Thank you so much, Dr. Effendi. That was really, 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 really good. We're going to move on to
Battling Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator